My name is Dr. John Bach. I'm a professor of physical medicine and rehabilitation and a professor of neurosciences at the Rutgers, New Jersey Medical School. And I'm going to discuss ways to avoid respiratory complications of polio, post-polio myelitis. This is an iron lung. As you can see, there's a dome on this structure. From the 1930s through 1950s, when people got polio and their muscles became too weak for them to breathe, they were placed in iron lungs. However, when the nurse had to open the iron lung to do some work on the patient, they would close the dome around the patient's head and they would provide positive pressure into the dome. These machines, these iron lungs, were made by Mr. Jack Emerson. And once I asked Mr. Emerson, why did you have construct a dome? Why didn't you just place a mouthpiece in the patient's mouth and let them get deep breaths that way? And he said to me that nobody had ever thought of it at that time. That's what Jack said. In fact, in this note by Dr. Affeldt in 1953 at Ranchos Los Amigos, he wrote that we even had a patient with no breathing ability who has fallen asleep and been adequately ventilated by having a mouthpiece in his mouth, so that it works very well and can do away with a lot of complications of tracheostomy, positive pressure. You just hang the mouthpiece by the patients and they grab it when they need it, and when they don't want it, they just let it go, and it goes from there. Back in 1956, Dr. Alba was in charge of the ventilator unit at Goldwater Memorial Hospital in New York. And patients were coming out of their iron lungs, and instead of getting tracheostomy tubes, as they were most other places in the country, the patients learned that the tubing from the ventilator, instead of going to a trach tube in their necks, they could simply get the air through a mouthpiece on the tubing, like this young lady is doing right here. And then in the 1950s, the patients started to refuse to go back into the iron lungs at night. So they fell asleep with a mouthpiece in their mouths, being ventilated that way, including many people with no ability to breathe whatsoever. I'm not aware of anybody dying as a result, and even though there were no alarms on the ventilators and the patients couldn't use their arms, their brains were intact and were able to see that they got enough air by grabbing the mouthpiece sufficiently, and they never lost the mouthpieces. The mouthpieces would not fall out of their mouths while they were asleep. Their brains would not permit them to do that. So back when I started doing this in the late 1970s, almost all of my post-polio patients had been 24-hour vent dependent since they got polio. But then things started to change. Back in 1993, a number of patients were what we call late onset non-invasive ventilator support dependent. They had been in iron lungs when they originally got polio, and they weaned from using them. But 16 or more years later, they started having symptoms of underbreathing, underventilation. They would get tired, they have morning headaches, and they would get sleepy. And they started to need nighttime ventilation. That happens about 16 or more years after the initial acute poliomyelitis. Then, around 2003, the majority of my patients with polio were actually late onset ventilator insufficiency. So they weren't all the patients that had been vent dependent since they got polio, but they actually got freed from the vents and the iron lungs and all of that, and then started to need to use ventilation at night again. Now today, some of those patients really need to use non-invasive ventilation day and night. And there are also some patients today who never needed to use an iron lung back when they got polio, who now, 50, 60 years later, actually need to use non-invasive ventilation. So the population that I'm seeing is shifted, but I still have a number of patients who have been on 24-hour ventilatory support since they had polio. None of these patients have tracheostomy tubes. Let me repeat that. None of the patients have tracheostomy tubes. After the age of 20, we all lose a little over 1% of every organ we have. And the vital capacity goes down by a little over 1% per year from the age of 20. So no matter what our ability is when we're 20, no matter what our vital capacity is when we're 20, it goes down after that. Now the vital capacity is when you're asked to take as deep a breath as you can and you blow it all into a spirometer And the spirometer just tells us the volume that you blew. So it's the deepest breath you can possibly take is your vital capacity. Normally, a vital capacity is over 5,000 milliliters. This young girl here is 9 years old, and she's in an iron lung with her parents and brother around her, children. I met her in 1977. That was 1952. In 1977, she has a sip and puff controlled wheelchair and a mouthpiece right adjacent to it. And she just rotates her neck, grabs the mouthpiece, gets deep breaths, and has been doing this now for 60 years. 60 years. She will never need a tracheostomy tube. She never needed one. And she has had no hospitalizations for any respiratory problems in more than half a century. 60 years since 1954, she has been mouthpiece ventilation user during the day. And she uses a lip seal at night, which I will show you. Now this man, 52 years, 24-hour non-invasive ventilation, and he has 0 milliliters of vital capacity for 52 years. Even though he cannot take any air whatsoever with his breathing muscles, he is an excellent glossopharyngeal breather. He is a frog breather. Just like my tie here, he's able to go and get deep breaths and ventilate himself all day without using a ventilator, even though he has no muscles below his neck. This is something that is impossible if you're being ventilated through a tracheostomy tube. And it's the reason why anybody with a tracheostomy tube should have the tracheostomy tube removed, because nobody with polio needs a tracheostomy tube. And the tracheostomy tube can cause a great deal of damage to the airway. And 4 out of 5 people with them and who are on tracheostomy ventilation die because of complications of the tracheostomy tube. This is a lady using a mouthpiece, and she kept the mouthpiece in her mouth for about 48 years. But then she had a stroke. And when she had the stroke, they trached her, and then she died after that. But the point is that the patients who had polio and were using non-invasive ventilation since the beginning, almost none of them have died from any respiratory complications. They've died from melanomas and other cancers. They've died from hypertension, from nervous system blackouts, and so on. This lady has a chin-controlled motorized wheelchair with the mouthpiece next to the chin control. So they have died from these things here, seizures, and so on, so on. But nobody, virtually nobody has died from respiratory complications unless they were given oxygen, and the oxygen then turned off their breathing, which I will talk about. How do you avoid respiratory failure and tracheostomy tubes? Well, it's very simple. Buy a $20 oximeter, and if your cough flows are less than 300 liters per minute. So in other words, if your cough is weak, you need an oximeter in your house for when you get sick, when you get colds. When you get a cold and your cough is not strong, your oxygen saturation may go below 95%. If it does, and you don't get it back up to 95 or more, because your cough is not effective, you will get pneumonia and go into respiratory failure. As you get short of breath, if you call the emergency medical services, the first thing they will want to do is give you oxygen. Almost all patients with neuromuscular disease, eventually they stop breathing completely because of that. When they call emergency services or they go to the emergency room, the first thing that's done is they're given oxygen, and when they're given oxygen, it turns off their drive to breathe, they stop breathing, and they arrest and they get intubated. This is avoidable by keeping your oxygen saturation normal, that is 95% or more, by providing ventilatory assistance when necessary and cough assistance. If, despite using non-invasive ventilation and mechanically assisted coughing, the saturation cannot be maintained 95 or more, you will almost certainly have pneumonia. So, anytime the oxygen saturation is less than 95%, there's really only 3 possibilities. You have a very high carbon dioxide from underbreathing, which is correctable by using non-invasive ventilation, or you have airway secretions because your cough is not strong. And if you don't get those secretions out and get the number back to 95 or more, you will develop pneumonia, lung collapse, gross atelectasis, etc., and you will need to be hospitalized. Now, if they give you oxygen there, you will stop breathing and they will intubate you. And once you get intubated, then the doctors will tell you that, oh, we're afraid to extubate you. We're afraid to take the tube out of your throat without putting in a tracheostomy tube. And you'll need a trach tube anyway someday, so you might as well agree to it and we'll put it in now. It's nonsense. Nobody with polio ever needs a tracheostomy tube. Nobody with muscular dystrophy or any other neuromuscular disease ever needs a tracheostomy tube for breathing. The only people who do are people with Lou Gehrig's disease, and that's because they develop spasticity in their throats that cause them to aspirate secretions that cannot be taken out by assisted coughing. That doesn't happen with polio or any other neuromuscular disease. So you need to have an oximeter at home. This is an old oximeter. Nowadays, the oximeters just go on the finger, and you can get them on the internet for under $20. At Walmart or CVS, you have to pay about $45. You don't need to use them every day, just when you get sick. But if it happens to be less than 95 at any time when you're awake, then either you're underbreathing or you have stuff accumulating in your airways, whether it be food or saliva, and you will have to cough that out effectively, or you'll eventually get pneumonia. If the oxygen saturation is less than 95 during the daytime, because you're underbreathing, then we give you a mouthpiece on a ventilator and let you take deep breaths until the saturation returns to normal, and then your symptoms go away. So far, I have been talking about daytime ventilation, but people begin to need ventilatory assistance for sleep. I want to show you, this is a lady using a cough assist, like a vacuum cleaner, to bring secretions out of her airway. And that's what you need to do. If your cough is weak, you must have an oximeter, and you need assistance coughing to keep your saturation normal. And if you can do that, stay away from doctors and hospitals, because they're extremely dangerous, and they'll probably kill you because they don't know how to take care of people with polio. I told you, the first thing they'll do is give you oxygen, which can stop you from breathing. So, learn how to do these things yourselves, and get an oximeter and a cough assist if your cough is weak. Now, these are babies who are supposed to die when they're 6 months old. And they can get trach tubes, and then they die when they're about 7. I told the parents of these kids that their kids would be dead within 1 year if they didn't get a tracheostomy tube. And now they're 19 and 17 years old. They have zero vital capacity. They cannot move a single muscle anywhere. They can't move their eyes anymore. They can't grimace. They can't move anything at all. They have 0 milliliters of vital capacity. They can move 0 air, but they don't have tracheostomy tubes. They survive using nasal ventilation 24 hours a day since they were 4 months old. Obviously, if these kids don't need a trach tube, nobody with polio does. This is another one whose father, I said to his father that he would be dead within 1 year without a trach tube. Now he's 22 years old. I was wrong there too. And patients with Duchenne, same story, 30 years of 24-hour non-invasive ventilatory support. This fellow I put on here to remind me to tell you that if you are solicited to get a diaphragm pacemaker, tell him to go and jump in a lake. It is not only useless for people with polio and any other neuromuscular condition, but it's absolutely potentially harmful, and it'll probably damage your diaphragm as well, just like phrenic pacemakers have been documented to do. They get $200,000 for putting in these things. They're totally useless. They can be useful for people with a high-level spinal cord injury, but there are not many of those. So to try to increase their market, they solicit their useless devices to people with polio and other neuromuscular conditions. This is a lady on mouthpiece ventilation, which you see her using here. She had polio around 1952. She's been doing this for 59 years now, 24 hours a day. And she works full-time for the last 30 years for Independence Care Systems in Manhattan, New York City. A wonderful person. Now, what she does at night is she uses this lip seal. So she's got the mouthpiece there in her mouth, but it's held in there with the lip seal with straps that go around her ears. And also, people who are a little bit overweight, they use mouthpiece ventilation. We remove the tracheostomy tube of this fellow and put him on non-invasive positive pressure ventilation. He needs it 24 hours a day. And this is a patient with polio whose trach tube we removed and converted to non-invasive positive pressure ventilation, and so on. Now, the problem is that you're going to have a hard time finding a physician who understands any of this, because physicians are used to treating people with lung disease, oxygenation failure, lung and airways diseases like COPD, like bronchopulmonary dysplasia, etc. For them, they are prescribed, oxygen and often bronchodilators. So that's what they also prescribe for people with polio. But not only are they useless, they are hazardous. Nobody who doesn't want to die should be receiving oxygen at home for polio respiratory problems. If you've been smoking and have severe chronic obstructive pulmonary disease, you can live longer with oxygen. But if you have not, and you have diaphragm weakness and you receive polio, you will go into respiratory failure sooner than if you receive nothing at all. We've done studies to show this. So some of the most common errors are misinterpretation of symptoms. If you're in a wheelchair and you're about to stop breathing, you're not likely to complain of shortness of breath. People complain of anxiety and inability to sleep, and that's because we can't breathe so well when we're asleep as we can when we're awake. The brain understands that, but the patients can't explain that to the doctors. Also, if you're sent for pulmonary function testing, that's almost completely useless for people with polio because it's designed for people with lung disease. I will show you what needs to be done. And nobody should have arterial blood gases done, and nobody should even think about a trach tube or airway suctioning. And no one should get oxygen therapy instead of normalizing your oxygen by normalizing your ventilation and effectively coughing out airway secretions. If you go to a doctor with muscle weakness and you're sent home with oxygen, you will be back in respiratory failure sooner than if nothing is done for you. And people who are managed with tracheostomy tubes have more episodes of pneumonia and respiratory failure than patients who are managed totally non-invasively. Also, you see, the oxygen not only turns off your breathing, but by keeping your oxygen saturation normal, even though secretions are accumulating in your airways, you're actually asking to get pneumonia by doing this. You've got to remove those secretions, you've got to cough them out, and oxygen is not going to help you do that. So, why not simply put a trach in everybody? I wish I had the time to tell you, but let me just say that 4 out of 5 people on trach ventilation die because of the tracheostomy tube. And 17 to 65% of patients with trach tubes develop severe tracheal stenosis. Here, the trachea is closed below the trach tube. When that's the case, we can't take the trach tubes out any longer. And the 4 out of 5 people who die because of hemorrhaging, connections between the esophagus and the trachea, mucus plugging, pneumonias, and so on, all of that caused by the tracheostomy tube. When our Lou Gehrig's disease patients do need trach tubes, they survive another 7 years on the average, but 3 out of 4 die because of the tracheostomy tube. They don't live 20, 30, 40, 60 years on 24-hour non-invasive ventilation with trach tubes. So you need to understand that there are 3 muscle groups: inspiratory, expiratory, and the throat muscles. The expiratory muscles are for coughing, mostly your abdominal muscles, and the bulbar innervated muscles are the throat muscles that you need to protect the airway and to permit you to cough effectively. What you need to have done is to have your carbon dioxide measured with this end-tidal flow, end-tidal CO2 monitor. We put the pick up at the nostrils. It's totally painless. You exhale through it and it tells us your carbon dioxide. And it's accurate. If you get an arterial blood gas done, 30% of people who have them done hyperventilate for the pain, and as a result, the CO2 is not accurate. Oxygen saturation. This is a $15 peak flow meter that permits us to know how strong your cough flows are, and a spirometer so that we can measure your vital capacity, your ability to take a deep breath, both sitting and lying down. And the lying down one is the most important because people begin to underbreathe when they're lying down. We also use this to measure what we call air stacking, where if your vital capacity is half of what it should be, that means you're not able to ventilate half of your lungs, and that half closes down. So we inflate people with air and measure how much air they can hold. We call that the maximum insufflation capacity. After the age of 19, we all lose more than 1% of our vital capacity per year. And as it goes below 40%, the cough flows become ineffective. So if your vital capacity is well over 40%, your cough flows may still be effective. So our goals are to maintain the lung health by inflating the lung to what it should be able to do, to optimize cough flows and maintain ventilation. So we air stack our patients. They blow it into the spirometer. We teach our patients how to frog breathe. That's like an independent air stacking. They can frog breathe up to way past their vital capacities, and we measure that. This patient is able to frog breathe to 3 liters, even though her vital capacity is only 900 milliliters. And this patient with 0 vital capacity can frog breathe all day, even without, and doesn't need to even bring a ventilator with him. And the second goal is to increase the cough flows, because mucus plugging, because you can't cough effectively, causes lung collapse, pneumonia. So to cough effectively, you need a deep breath. You need about 2.5 liters of air as a normal cough volume. But then you need your abdominal muscles to create pressure and your throat to hold that pressure. So first thing we need to do is we pump up our patients. They air stack to a deep volume, press on the belly, and then we can measure those flows. And they cough through the peak flow meter. And if those flows are under 270 or under 300, you have a risk of getting pneumonia when you get bronchitis. The flows increase by assistance to where they become functional. And this is the main reason. If I had to show one slide why we never have to consider trach tubes for people with polio, this would be the one. Because with manual assistance alone, we can make effective cough flows to prevent pneumonia and respiratory failure. This is a 1953 cougholator, which gives you a deep breath through a mask, and then the pressure drops to a negative pressure, and it causes 10 liters a second of expiratory flow. This patient with polio solicited the journals, newspapers for someone to make this machine. I found Mr. Emerson to do it. He got a 10-gallon paint can, put a vacuum cleaner motor in it, gave it to me in 1988. We used it to clear the secretions of our patients, and now they have 5 generations of this in the Philips company, and there are 8 other companies around the world who make them. That's the one from Philips. It's called Cough Assist. And so we use it, and the mucus comes flying up. The patients avoid pneumonias. This fellow would never have needed a tracheostomy, would never have needed a ventilator if he had his trach tube removed. But he was convinced that within 1 year he would be cured. All he had to do was raise enough money. Although he kept his ventilator and didn't get his trach out, he brought his cough assist with him all around the world, as you can see here, because he realized that using it through the trach tube was much more comfortable and effective than being suctioned. But if you have a cough assist, use it at pressures of 50 to 60 centimeters of water. Don't use it at less than 35 centimeters of water. It just won't do very much good. The final thing is to maintain your ventilation all the time to prevent these symptoms of fatigue and sleepiness. You start nasal ventilation at night, and if you get weaker and you get shorter breath, when you take off the ventilation in the morning, you need to switch to a mouthpiece during the day. Now, the settings that we use are volume settings. We don't use BiPAP anymore, because with BiPAP, the EPAP is counterproductive. It subtracts from the deep breath we want to give you, and you cannot air stack to a deep volume to be able to keep your lungs healthy and to be able to speak longer and louder. So we use volume cycling. So we'll use the Trilogy or the LTV ventilator, and we'll set it on a volume of about 1,000 or more milliliters, and you take as much of the air as you want during sleep through the nose, nasal ventilation on volume cycling, and during the day you can use the same settings through a mouthpiece. You use these full ventilator settings so you can rest your muscles at night. Your tired, weak muscles, you can rest them at night so that during the day you can be strong and maintain normal carbon dioxide. So this is a portable ventilator that can be used on volume cycling or pressure cycling. But we prefer volume cycling for the reasons that I said. Don't think about negative pressure anymore, because the iron lungs and the chest shells that were used in the 1950s cause obstructive apneas. It is never as effective to use negative pressure as it is to use nasal ventilation or mouthpiece ventilation. And there are so many interfaces on the market now that you can always find one that's comfortable for any nose. This is a pneumo belt, by the way, that also ventilates patients, but you wear it under the clothing, and I'm not sure if Respironics still makes them, but we still have them, and our patients still use pneumo belts. If you notice, the air comes from the ventilator, goes to a girdle on the stomach, there's nothing in the nose, the mouth, or the neck. And it ventilates the patients very nicely. This lady got intubated because she fell and actually broke her neck. And I was away. She got intubated. I came in on Monday, and we extubated her to nasal ventilation. She has no ability to breathe whatsoever, but she did not get trached. So we let her use nasal ventilation, mouthpiece ventilation, and lip seal. And we let her choose what she wanted to use, and she's able to go home. So now we have had 250, or more than 250 patients, over 100 since 2010, who have been transferred to us because they didn't want to get trach tubes. And I advise you all that if you ever get pneumonia and you have polio, don't ever consent to a tracheostomy tube. I guarantee you, you never needed it, you will never need it, and you don't need it at that time. So tell your doctors to give me a call. Get transferred to us if they don't want to learn how to do it themselves. And it's very difficult for them to learn how to do because their therapists and nurses are not experienced in using non-invasive ventilation or mechanically assisted coughing. If you mention non-invasive ventilation, they'll say, oh, sure, we know non-invasive ventilation. We put people on BiPAP all the time. That is not non-invasive ventilation. Non-invasive ventilation is when you know how to use it 24 hours a day, including through a mouthpiece during the day. If a doctor says they understand non-invasive ventilation, you ask them that simple question. How many people do you have on 24-hour non-invasive ventilatory support? I guarantee you the answer will be 0. So you'll have to be transferred to us, or I can educate your doctors and talk to them. We also take the trach tubes out of people, like her, who are 24-hour vent dependent, and convert them to non-invasive ventilation. And this patient is on trach ventilation. We take out the tube, and she needs 24-hour support. We put on a pressure dressing, and she continues nasal ventilation at night and mouthpiece ventilation during the day. Okay, I recommend you get some more information on one of my websites, which is drbach.com. And I have a website at my medical school too, the Rutgers, New Jersey Medical School, but I usually refer people to this website. I have 7 books previously. This is the one that's most relevant to people with polio, and I hope by next year to have an update of this book. It's really not in print now, but it's possible to get it on the internet from abebooks.com, abebooks.com. Okay, thank you, and good luck.